Turn the microphones on. Hello, my name's Tom Farden and welcome to Grand Rounds. The first thing to point out is you will notice that we are on one screen now, and on that far screen over there, that is the Gillingham room in Perth Royal Infirmary. We are finally live streaming to Perth. There is no one there to see it. Because this is just a test, but it does work. So I'll be telling the Perth folks next week to turn up. And we can actually now video conference in from any of the hospitals in NHS Tayside, so Arbroath and Stracathro mainly. And we're working on getting people to video conference in from primary care. But it has only taken me 18 months, but we're finally there, albeit to an empty room. This week in Grand Rounds, we're delighted to have Martin Van with us, who's just disappeared. No, he's not, he's over there. And he was going to be accompanied by Quentin Gardner and Gohil Rohit, but they've both cleared off. Apparently Quentin's in Edinburgh operating, and Gohil's also operating at the moment as well. So he'll be by himself, so go easy. And from what I've read already of the case, I'm sure he's fully prepared for the onslaught. Now, some of you will have noticed another new invention this week in the form of the Dundee Grand Rounds newsletter. So up till now, I've maintained a mailing list to try to get out to all of you, an email out to you all, but it's very reliant on other people, mainly secretaries, who forward things on for me. Now, in this new newsletter, you can follow the link that allows you to subscribe or unsubscribe from the weekly newsletters. So if you could go on to that, I'm going to start moving away from relying on secretaries and goodwill towards using this newsletter. So if you sat there thinking, I never get the newsletter, please go on to the CMDN, that's the college website, and click in the blurb where it says subscribing to our newsletter. The Saudi Arabian Embassy Cultural Attaché has signed a contract with the University of Dundee to train outstanding students from their country as medical doctors and dentists. This is the first formal agreement between the Saudi government and the university, and will fund 3 annual intakes of medicine and dentistry students to a bespoke 1-year foundation course, and a total of 8 students are expected to join each intake. So this is an ongoing plan of the university and the NHS through the Academic Health Science Partnership to improve international outreach and bring excellent students from all over the world to come and study with us. If you are a final year student, please go online and complete the National Student Survey. So you could go to a ball for free, or you could win an iPad. We've hit our 75% target, but it would be nice to catch those dentists eventually and get 100%. On Tuesday the 5th of May, Dr. Michael Gordon, who's a distinguished geriatrician and palliative care specialist from Toronto's Baycrest Centre, is here to deliver a lecture entitled Managing Ethical Challenges in Late-Stage Dementia. We had a dementia-themed presentation earlier on this semester, and I know that if you're a junior doctor, you'll have seen all the posters on the walls on how to identify patients with delirium and differentiating it from dementia. On Thursday the 7th of May at 5 p.m. here in the Ganachie, the Tenevus Committee hold a scientific meeting with presentations from some of our own Tenevus grant holders, such as James Chalmers and Jacob George here. This will then be followed by a reception. If you're interested, then please contact Victoria Borthwick, whose email is at the bottom of the page. For those of you who are into big data, healthcare informatics and getting your name known and networking, don't forget about the FAR Institute and the Institute meeting in St Andrews. The website isn't on there. It's www.farinstandrews.org. And I'm going to steal a little bit of Martin's time to talk to you about something that Paul Fettis and I and a number of other people have been working on for the last, 6 months in support of the Archie Foundation. And this is the Archie Mountain Challenge. Archie came in the first semester of this academic year to talk about their partnership with NHS Tayside in raising funds to build a new children's theatre here in Ninewells. They already fund hospitals in Aberdeen and in Inverness, and this is the furthest south that they've ventured. And what Paul Fettis and his team have come up with is a fairly adventurous, optimistic plan to raise some money for the Archie Foundation and to get some publicity. The background comes from this man, who I think looks a little bit like John Dick with a funny hat on. He's just left the room, actually. Maybe I'll show him the picture again. This is obviously Sir Hugo Munro, the King's Messenger, who climbed all of these mountains and plotted them all, and we now call these mountains that are over 3,000 feet, we call them Munros. But we don't work in feet anymore, we work in metres. So 3,000 feet is not quite 1,000 metres, but what if you look at the mountains across Scotland that actually are over 1,000 metres? How many of those are there? And this is the metric mountains, and we've decided we're going to call these the Archies. You see there's about 130 of them spread across Scotland, and they're all on mainland Scotland, which is helpful. The plan is that we're going to climb every single one of these mountains, and we're going to do it by running up them, and we're going to go between these mountains by human power alone. So they'll be running up the mountains. We're going to mountain bike or cyclocross bike from the roads to the bottom of the mountains. We're going to cycle between on the roads between the mountains, and there is a little bit where we're going to have to use a kayak to get across. This is the first time anyone has tried anything as ludicrous as this, but we're going to do it. This is the route. We're going to start here in Dingwall, and we're going to go a bit northwest, and then we're going to come south, and there's a big schlep here across to the Cairngorms. This is about 100 miles, so we're going to cycle across that in a big team, and then there's a week in the Cairngorms before we go down to the top of the Trossachs, and we end up down here at the Rest and Be Thankful, which I think we will be grateful for the rest and certainly thankful. So this is happening between I think it starts on the 30th of June, and it's going to be happening for 3 weeks, and there's already plenty of Nine Wells folk who are signed up to do this. If you think you'd like to volunteer and help, if you'd like to run up a mountain, cycle between them, cycle up them, if you'd like to drive the van, if you'd like to sponsor anybody, then please get in touch and I'll point you in the right direction. He's back. John, we found a picture of you. There is going to be 3 climbs which are going to be walks, family walks. And the first one is on the first day, and then we're going to go in the middle of the second week, we're going to go up Schiehallion, so that's about here-ish, and on the last day, we're going to climb at the Rest and Be Thankful, all as a family walk. So there'll be more information about that I'll tell you at next week's Grand Round and Grand Rounds to come. But to increase the madness, this is something of my own stupid invention, that we're going to, on the 14th of June, my cycling club, which is Castlegary Velo, and a number of the cycling clubs around the city, have decided that we're going to try to climb into space. There is this concept of Everesting, where one person climbs one climb enough times to climb into space. We felt to climb up Everest, which is 28,000 metres, and we thought that was ridiculous. That's too easy. So we're going to try and climb into space, which is 100 kilometres up. So as a team, we're going to climb up the Abernight climb, if you know where the Scottish Antiques and Arts place is, halfway up the road to Abernight. That is about 160 metres of vertical ascent over a 3.5 kilometre horizontal climb, and we need to do that at 625 times. So we're going to do 625 ascents of Abernight in 12 hours on the 14th of June. So if you want to be involved, let me know and we'll get you signed up. And the idea is that if you think you could do it once, that's great. If you think you could do it 20 times, even better. If you think you can make 50 climbs, and that's up Everest, then that's even better still. But we're going to be camped out in the Abernight antique place from 8 o'clock in the morning to late at night. I'll give you some more information about it in coming weeks. And that's enough about the Archies for now, but I will be drip feeding you more information as we come along. The Adventure Show, the BBC Two show with Dougie Vipond, they're going to be filming us doing it. So if you do get involved in any of this, you'll be on the telly. Right, on to Martin and his presentation, intriguingly entitled, "The Case of a Stone and a Swelling, a Unique ENT Case," which is a bold statement. So let's see how unique it really is. From the beginning, Martin?
Yes.
Here we go. There you go.
Thank you very much for inviting me to speak at Grand Rounds today. My name is Martin Van. I'm one of the FI1s currently doing general medicine in Perth. But in my first rotation, I was on ENT. And today I'd like to share with you a highly unique and interesting case that we came across. And I think of this as the case of a stone and swelling. I'm going to go through the case in itself and then give you a quick overview of head and neck infections, focusing specifically on supraglottitis, and then summarize our findings at the end. So the head and neck is a highly fascinating area of the body, and by the end of this talk, I hope to share with you my enthusiasm and give you some insight into the acute management of adult supraglottitis. The epiglottis is a broad fan-shaped structure that lies superiorly and anteriorly just as you look down into the larynx, similarly like the seashell pictured here. I want to clarify two terms I'm going to be using, epiglottitis and supraglottitis. So, more commonly in children, you get infection and swelling of the epiglottis, which is termed epiglottitis. However, in adults, this swelling is not limited usually to the epiglottis, but to the surrounding structures as well. And this is what we call supraglottitis. And this involves all the structures above the vocal cords and any structures within these brackets. So let's move on to the case. It was a Thursday afternoon back in August last year. A 70-year-old lady came in with a right neck swelling. She had difficulty swallowing and pain. She looked slightly out of breath, but she had no stridor. However, there was a change in the quality of her voice, and these symptoms have been progressively worsening for the past 2 days. She had this swelling of her right neck for the past 4 weeks and was previously seen in the ENT clinic. On examination on that day, it revealed a smooth swelling, but nothing else remarkable, and she was sent for ultrasound scan. The scan showed some prominent vessel in the right submandibular gland, but nothing else, and a biopsy and tissue sample was inconclusive. On examination, her SUS was 0, she did not have a fever, she had a right neck swelling under her right mandible measuring 15 times 8 centimeters, which was tender and hot. So, on inspection of the oropharynx, there was a uniform swelling of the floor of her mouth, but otherwise, cardiovascular respiratory examination was unremarkable. Now, presenting with these kind of symptoms, we wanted to have a look and directly visualize the larynx. And this is the gold standard investigation. So, I'm going to show you 3 pictures here. The first one is a representation of a normal larynx. So as you go through the nostril back towards the postnasal space and look down into the larynx, you'll see the epiglottis at the front. And on the sides, like a staircase leading down to the arytenoid cartilages, you have the aryepiglottic folds, and the white band-like structures in the midline are the true vocal cords. However, when you get swelling of the epiglottis, you can see this represented by the second picture. And the third picture is what we saw in our lady that presented. And this was swelling of the supraglottic structures, so not only the epiglottis. And you can see how the laryngeal inlet has been minimized to just that black hole there. And this is a potential airway obstruction if the swelling continues to grow. Now, how did we manage her? So we called for urgent anesthetic review. We sent off bloods, cultures, and we fluid resuscitated her and commenced her IV antibiotics and steroids. Now, her bloods showed a slight increase in CRP and white cells, which is in keeping with the infection going on. But in terms of her right neck swelling, we also want to exclude any abscess formation or tracking of infection in her neck. So we order an urgent CT neck. So in the first slide, we can see that there is swelling of the right supraglottic structures here. And looking at the original larynx, you can imagine how the work and effort of breathing increases exponentially, thinking back to Pusey's law, which is the radius to the power of 4. And that explains her dyspnea. Now, in the second picture, we see enlargement of the right submandibular gland, and this was not previously detected on the ultrasound scan. So this is in keeping with sialedenitis, infection, inflammation of this salivary gland. However, the third picture reveals something interesting, and this was the culprit that led to this series of events. And behind the lower right incisor, we can see a salivary stone measured 3 millimeters, and these commonly form and cause localized inflammation and then ascending infection back into the salivary gland. But Our Lady had a rare complication, which was backtracking and spread of infection further through the different neck spaces, causing inflammation of her supraglottitis and leading to potential airway obstruction. So how did she do? She was conservatively managed with high airway vigilance. She was treated on the ward with IV antibiotics and subsequently improved. And after a few days, the stone was removed successfully under local anesthetics. Now, this is just a diagram of the summarizing the events. So salivary duct stone leading to inflammation and infection of her submandibular gland, which tracked back and caused potential airway obstruction by inflammation of her larynx. And this case is highly unique. And when we searched the literature, there was nothing similar described. So, thinking about the head and neck and the infection in these spaces, we need to have an appreciation of the anatomy. So, there are two main fascial compartments, the superficial and then the deep compartments. In the deep compartments, there are different layers of fascia that create real or potential spaces. And this is just an overview. I won't go into the detail of them. And this is a lateral view here. But if we think about the neck as ochre in this picture, we can see the different compartments. And it's easy to imagine that the different structures held in these compartments are surrounded by these different layers of fascia. And thinking about infection, we can see that they would easily track up and down along these different layers. And this is important because it allows us to predict the spread of infection in head and neck. So superficial neck infections generally cause little problem. However, we're interested in deep neck space infections because of its potential to cause airway obstruction. This man is Hans von Ludwig, and a condition that was named after him was Ludwig's angina. He described a condition that caused an inflammation of the fascial layer below your tongue, which is an airway emergency. This swelling causes the displacements of the tongue upwards and backwards, and in 75% of cases, quotes in the literature, these patients need a tracheostomy. Now, I want to focus this presentation on supraglottitis, though, and it's a very rare condition. Could I get a show of hands? How many have actually seen or been involved with a patient with epiglottitis or supraglottitis? It's quite few. Just about 6 people in this audience. So the epidemiology is quite interesting. It's quoted as being about 1 to 4 in every 10,000 incidents in the adult population per year in the UK. And I'm saying that epidemiology is interesting because it's been experiencing a shift from mostly being a childhood disease with epiglottitis. However, after the introduction of the Haemophilus vaccine in 1992, this has been on a steady decline. And instead, we now see an increase in the adult population. And there's quite a high mortality, quoting everywhere between 7 to 20%. And it's thought to be due to its rarity and also its difference in presentation in the adult population. So it's commonly misdiagnosed and commonly mismanaged. So how does it present? Well, it presents with more of a vague, indolent course. In the pediatric textbooks, we know that the classical epiglottitis presentation is the tripoding, you have the drooling, the trismus, the stridor. You usually don't get that in adults. 90% present with pain on swallowing and a sore throat. Whereas less than 50% in the literature describe stridor, which is a very late sign, any drooling or any trismus. Or even there's numbers to say that less than 35% even have any respiratory distress. But it can be quite deceiving, as with the case in Our Lady. Her SUS was 0, she was afebrile, but these patients decompensate quite quickly. So other signs are being generally systemically unwell, lymphadenopathy, anterior neck pain, and fever. So how do we manage this? The important step is to diagnose it first. And the gold standard would be direct visualization. However, if there is a high suspicion, then we must not let that delay any treatment. And effective treatment is to first prioritize the airway, make sure it's secure, and that it's closely monitored if it needs to be secured, either by endotracheal intubation or surgical means. And the second bit is to treat the infection that's causing the swelling. So IV antibiotics as appropriate. And you might ask, is there a place for steroids or nebulized adrenaline? Well, the literature has so far only produced case series. So we're still awaiting conclusive, systematic, randomized control trials that show any benefits. And so far, there's a debate about its benefits in terms of mortality and morbidity. So in conclusion, we describe this unique case where salivary duct stone caused salivary gland inflammation, and then the rare complication of this tracking back and causing inflammation, infection of the supraglottic structures. We've also want to highlight the importance of recognizing these often vague symptoms in the adult population, and then in terms of management, making sure that airway is the first priority, and then treat with antibiotics to avoid potential fatal complications. I'd like to thank my supervisors and Dr. Young for providing the CT images. Thank you very much.
Right, thanks very much. So, we've got plenty of time for questions. Anyone have any questions for Martin or any comments? Have any ENT surgeons turned up? Oh, look, the one's waving. Excellent. So you have some support. They have a friend in the back. Any questions for anyone? Which antibiotics did you use? What's the causative organism in this?
So, in most cases, there's actually not a positive culture. But these are the organisms that are implicated. So, as I said, in most cases, there are no cultures, but the Tayside guidelines is to use a broad-spectrum cephalosporin, so ceftriaxone.
Okay, that's a fair list. Don't see a lot of pastorella, I have to say, but anyway. Anybody else got any questions? Comments? Anything? Does our ENT surgeon want to say anything?
The only thing I was going to say, like Martin said, you might see this in a scenario where you have got maybe suspicion of diagnosis before you get visualization reports or get involved. I would say there is a role for steroids and nebulizer, it's only a holding measure to make definitive interview to put airway intervention in. But also they do reverse the swelling somewhat, and that gives you sometimes you can avoid the need for intervention, surgical or facial intervention. And the other thing is heliox is very good in these scenarios. Heliox is not going to use oxygen. It's not available for all the water, but you have to have it in ENT. If one day you had a diarrhea in emergency, you try to get hold of some way of maintaining the airway, the benefit of heliox is to do with density in the gas. It allows you to maintain oxygenation even in a very narrow airway. So it's just another thing to have in the toolbox if you are in a specific situation. Heliox in the ENT will help you at least keep getting oxygen in the need.
Okay, so for the people who couldn't hear, it's the last comment was about the use of heliox in tight airways. And we don't use a lot of heliox in the respiratory world, certainly, but I do know it has its uses.
I don't think it's often used, but it's one of those things to have in your mind if you are struggling.
Well, the one thing I know about epiglottitis is don't try and visualise the airway. We were taught that in A&E, and presumably it's the same idea with supraglottitis, that if you suspect it, you don't start faffing around trying to look down people's throats.
I wouldn't do it with a tongue depressor as such, but there are studies that have looked retrospectively at this and said that fiberoptic laryngoscopy is safe in adults.
I suppose it's the operator that's safe, really.
Adults versus children. In children, definitely avoid it. The ethnic dynamics of children are so different that if you aim to trick that narrow airway to more narrow, either by stressing the child or triggering a reaction, then it's worse. But in adults, I mean, be cautious. They're already switched. If you're going to don't correct them up, don't. But with adults, you've got a little bit more leeway than children.
Okay. Anybody else have any questions or comments? If not, we can call on early bath. Thanks very much, Martin, for a somewhat unique presentation. Of a somewhat unique presentation. Next week, it is Acute Kidney Injury Week. You should have had some emails flinging around about new biochemistry alerts of what AKI looks like on ice, and Samira Bell is going to present on AKI. I have no idea what she's going to talk about, but I'm sure it'll be interesting. It will centre around acute kidney injury and its detection across the hospital. I'll give you some more information about the Archie challenges. Please think about if you want to get involved. And until next week, thanks very much for coming. See you next week.